My name is Dr. David Gratzer. I'm a psychiatrist at the Center for Addiction and Mental Health in Toronto. I'm very pleased to be able to comment today at Dr. Becky Inkster's conference. I had attended in person 3 years ago in London, and now I'm attending virtually, as we all are. Much has changed over these last 3 years, but the passion and energy of Dr. Inkster has not. So first things first, thank you very much for the ability to present. And Dr. Inkster, congratulations on what seems to be the makings of another successful conference. For the next few moments, I want to talk about the incredible transformation that's taken place in mental health care services and what are the implications moving forward. I'm going to draw heavily from an editorial that I've co-written for the Canadian Journal of Psychiatry, though my thoughts aren't exclusively from this editorial. I should acknowledge that there are co-authors, and my conversation today with you draws on these conversations, and of course from the editorial. Dr. John Torres, by the way, is one of the co-authors, and he's another speaker at this conference. Are we having a digital moment in mental health care? What an extraordinary change we've had with regard to COVID. I'll speak first from my organization, the Center for Addiction and Mental Health, the largest mental health hospital in Canada, where we've seen so many outpatient services converted over to virtual care. The statistics are from March and April, and we're not in April anymore. There was an 850% increase in outpatient digital services. Kaiser Permanente in the United States now delivers 90% of all mental health care digitally, and other organizations are reporting similar things. There's a short paper in Psychiatric Services that looked at 20 psychiatrists. The majority had not used any virtual care before the pandemic. All of them were using virtual care now. And of course, if we look over the private sector, we see the use of apps has grown more popular as well. We Talk, which is one of these very popular counseling programs, it's Talkspace, reports that they've had a 65% increase in their users. This is such a marked contrast from just a short time ago. There was a paper looking at Medicare providers in the United States and who used digital services. Just 5% did any telemedicine when it came to mental health care. We know that there's great evidence to support a lot of what's going on. As an example, we can focus on telepsychiatry. There's decades worth of literature on telepsychiatry showing, in fact, that the user engagement is good and that patients actually like this service. If we look at internet-delivered cognitive behavioral therapy. So cognitive behavioral therapy, which as you know, is a very evidence form of psychotherapy, except it's delivered over the internet. We see that there's good adherence rates and can match in-person cognitive behavioral therapy if done right and thoughtfully. There's less evidence for apps, but there are apps on the market which seem to be very thoughtfully done, and we know that there seems to be incredible interest in apps. Some of the most popular apps have hundreds of thousands of downloads, like PTSD Coach. We're having a digital moment, perhaps, but it's also important to acknowledge the limitations of a digital moment. So to go back to telepsychiatry, there's less evidence to support telepsychiatry for people with severe persistent mental illness. Internet cognitive behavioral therapy has robust evidence, I think as an example of a recent review published in the Canadian Journal of Psychiatry. But it's also true that when simply added on to an offering of family doctor services, dropout rates can be incredibly high. And with regard to apps, we know that apps can be popular, but we know that apps also can have difficulties with patient engagement. 96% of users didn't engage in app after 2 weeks, which was found in a recent study looking at apps that had more than 100,000 downloads. So we've had a rapid embrace of digital mental health care, in part because we have no safe alternative. We have tremendous interest. But moving forward, what have we learned and what is I would suggest that there are great things that have come about in recent days, but we need to proceed with caution. I would forward some specific recommendations. First of all, we need to continue but review compensation and regulatory reforms. So I speak today from Ontario, Canada, where one of the first things the provincial government did was to fund virtual visits. Those include telephone visits. And I think moving forward, we need to continue to do this, but to do so thoughtfully. As an example, there's no requirement that I use a safe platform. I could use a platform that is less safe. Zoom, as you know, had some difficulties early in the pandemic. So again, moving forward, as we review compensation and regulations, we need to do so in a way that's safe. Secondly, I would suggest that we should be very cautious about privacy. So again, tying hand in hand with decisions we've already made, we need to understand that as more service moves online, digital privacy becomes more relevant and more important. Historically speaking, we've thought much about patient safety. When I wish to access a medical record in my hospital, I need to sign in. It takes an imprint. When I sign out, everything has a digital fingerprint, so to speak. We think so much less about that when we think about digital privacy, and yet it's just as relevant. John Torres has a quick suggestion for all of us providers. When you talk to your patients about apps, be sure to mention to them that they should check for a digital privacy policy. Good advice. Personalized care. We've happened upon this moment, but moving forward, I think a lot of service is going to continue to be virtual because it makes sense. You know, I work in downtown Toronto. When I want to do a follow-up appointment with one of my patients, my offer isn't very good. I suggest to them that they should come down and see me, which means they should take a half a day off work. They should try and find parking downtown, which is feverishly expensive. Then they should sit in a waiting room and wait for me. And of course, there's reasons for this, but the clunkiness of it means that a lot of our patients don't show up for appointments. The person who needs a simple med check might do well not to take off a half day, but maybe to take off 20 minutes from his work because his work's important. And now that he's feeling better, it's actually a priority to keep that job. So moving to personalized care, one can think about under what circumstances should we offer digital services. Jay Shore, who's been doing digital psychiatry for so many years, he wrote a very clever piece in JAMA Psychiatry, and he suggested that we should ask some basic questions. How much virtual care is too much? Is there a virtual saturation point? At which the benefits of a virtual relationship decrease or patients request more in-person interactions? Good questions. Ultimately, one can see virtual care as being part of a menu of options guided by resources and patient interest and the best evidence. And so somebody might want to do an in-person psychiatric consultation, but follow up for cognitive behavioral therapy online, or maybe part of the cognitive behavioral therapy would be online and part of it would not. But these sorts of things need to be thought through and need to be thought through carefully. And of course, we need to address inequities. You know, I note as we've moved to a virtual moment in education, a lot of public education in North America now is done virtually. There's been a real effort to address inequities. As example, school boards in my city have provided iPads and data for kids who don't have access to that technology. What are we going to do to close the virtual care gap in terms of inequities? So, thinking about North America, and our conference scores aren't only thinking about North America, of course, I point out that some 20 million North Americans lack access to broadband. There's another gap as well, so it's not just the technology gap we need to address, it's also the knowledge gap. So some patients, one can think perhaps of older patients, though not exclusively so, would have access to the technology but don't need to use it. How can governments working with the not-for-profit sector and maybe even the for-profit sector offer the technology for those who need it and offer the training for those who need it? And finally, I think we need to invest in research. We have done very well in rolling out all of this care in a short period of time, but we still have a very poor sense of who would do better with internet-delivered cognitive behavioral therapy as opposed to in-person cognitive behavioral therapy. We have limited understanding of which subpopulations would prefer chatbots and which subpopulations would find this clunky and unfortunate. I'm not suggesting for a moment that we won't have surprises when we do that. Already we've had some surprises. There was that clever paper out of Cambridge that looked at 96,000 hours of internet-delivered cognitive behavioral therapy, showing certain things reduce the dropout rate and improve overall outcomes, such things, for example, as homework. And so I see our digital moment as being a moment of great scientific curiosity and questioning. Wouldn't it be wonderful to understand better who responds to different interventions at different points in time? We have much already offered, but perhaps the overall quality isn't as good as it could be. Vigo in the Canadian Journal of Psychiatry wrote recently, most existing tools are still underdeveloped, underevaluated with poor user engagement, and do not fully leverage state-of-the-art artificial intelligent mechanisms. Well said. But as we move forward, we can address that. I'm bullish on this moment. I've been a practitioner now as a doctor for some 20 years, and I've seen so many of my patients over the years drop out because our model was clunky, because we asked patients to come downtown in the middle of the day and take a day off and they wanted to stay at work, or perhaps they were busy because they were a single mom, or perhaps they had obligations because they're a small business person, they needed to be in their shop. So this is our digital moment, and there's great potential, but there's also problems. The evidence, as I've suggested, is heterogeneous for things like apps. We need to understand better the tools that we're using. And so here we are, once again at Dr. Inkster's conference. Here we are once again considering digital mental health care, and here we are once again enthusiastic, but perhaps a bit cautious. Not just because there's a pandemic, but because we have a great opportunity to move forward. Unfortunately, this is a pre-recorded conversation, and as a result, I can't engage you as I would like. You're welcome, however, to pop me an email and continue this conversation going, or of course, you can tweet me on Twitter if you're into social media. Thanks again for the conversation, and thank you again, Dr. Inkster, for having put this together. Becky, you're a remarkable person. Cheers.